And we will have conversations with people who would suggest that people have taken a medicine for weight loss and that is an easy way out when these people are living with a chronic disease.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision making in the boardroom. Join me, your host Asma Yunus, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Hi everyone, welcome to Health Chat. I'm your host Asma Yunus, and today we're going to be talking about something that over the last few years has dominated headlines, clinical conversations and also patient demand. We're going to talk about modern obesity management, and joining me on this episode I've got award-winning clinician and bariatric physician Dr Anjali Zalin. Thank you for joining me. Now you hold a PhD from Imperial College London, you've secured millions of pounds worth of grant money for funding obesity services, and you focus on clinical innovation, cross-specialty pathways and digital health solutions. That's what I have you down as. So really appreciate you taking the time to join us. Can you tell me a little bit first about your journey into bariatric medicine?
Yeah, of course. Well, thank you very much for having me. So I started off training in diabetes and endocrinology as a specialty, and I had the opportunity to do a post in bariatric medicine. And when I did that, I just got hooked. There were many aspects of that job that I really liked. So I think one of the things I liked was the ability for us to be able to treat chronic disease and see a remission in certain conditions that we had previously assumed were progressive. So that was really positive. And they had a really great culture, this multidisciplinary team working. So that was something else that I really enjoyed. And when I started to think about my background in diabetes, endocrinology, obesity medicine really had everything because I could use all of those skills.
How long have you been in the field?
So probably at least 15 years,
Okay.
I would say, yeah.
Do you feel like over the last decade, when we look at obesity care, that it's really kind of evolved from where you started?
Absolutely, yes, it has. And I think we've got many more options now available to people, which is great. We didn't have so many. And I think there's a lot more awareness about obesity as a disease. So I think we've definitely advanced.
I want to get into sort of the ins and outs of obesity, but I feel like we need to address the fact that one of the biggest shifts recently has been the rise of GLP-1 weight loss medications. So it is prevalent in the press, in people's socials, it seems to be everywhere, and obviously in clinics and as well, and there's a lot of demand. Why do you think? Because essentially it wasn't created for obesity, but has somehow shifted into that market. Has that been a good thing for you?
Certainly there's a lot of interest and people come asking for medical therapies. How people can access in our public sector is obviously different to how they can access privately. So that's just it's a bit of a balancing act. I think with any sort of interventional treatment for weight loss, we would want to do a holistic assessment of that individual. We want to understand the risks and risks and benefits rather, and make a shared decision with them. So it has given us more tools, and we can have a lot more sort of intelligent conversation with people because, there's just a lot more awareness, I would say. So it's been a positive thing, I think.
When we think about the medications themselves from your perspective, are they safe to be using long term, or is the key thing there, as you mentioned, having that wraparound care with it?
Yeah, so I think it's understanding the individuals and they're developing a personalised approach to them. So for some people, they may need to be on it longer than others. Some people might want to take a shorter course because they're getting ready for something like a specific surgery or something like that, in which case that would all be sort of clinically supervised. So I think everybody's going to be different. Anyone who's on these drugs should have them, treatment should really have them regularly reviewed and be under the care of a healthcare professional, really.
For those interested in or who are maybe taking these medications, what are the most common medical risks or complications that you've seen?
Okay, so people do have side effects, which we counsel our clients, our patients for. And I think a lot of the time, if people are aware of that, then they can manage that effectively. There are certain specific medical reasons why we wouldn't put people onto certain drugs, of course. So we would screen our individuals for those conditions. When they go onto that, we always advise them, this is one tool as part of a bigger piece. So we would need to manage diet, psychology, movement, all of these things. So when somebody's taking a medical option, they would want to be part of a bigger package, essentially. So we would potentially also tell them about some of the risks and things to watch out for.
Just a thought, in your experience, have you ever seen anything like this, where there's been such an explosion in demand? Has there ever been a drug that's maybe come close, or a treatment that's come close that people have gone a bit nuts for?
Well, I think in my experience, in my line of work, this really has been unprecedented in terms of what we're experiencing now. So yeah, it's very interesting time to be part of this specialty, and we'll see how it evolves. I think, like everything, there'll be peaks and troughs of activity and interest. So yeah, we'll see.
Because of that demand, has it been difficult in any way, or challenging you in a different way?
Yes, I think so. I think as clinicians, responsible clinicians, as most of my colleagues are, we just need to be vigilant, mindful to the people for whom these treatments may not be appropriate. So if we think about it in the way of any other drug, these are prescription drugs. So what we sometimes have the narrative shifting to people wanting to go on them, which is a very different kind of approach to a drug. Whilst we have a shared decision, ultimately a prescriber takes responsibility. So I think those conversations can sometimes be challenging. People understandably want help, and they are often, really feeling like they've struggled for many decades. So if we have effective interventions, then those, it can be difficult sometimes to navigate those conversations. But, I think it's all about the communication that we have with somebody, getting to know them, understand what they're trying to achieve.
And I feel like the innovation in this is pretty fast. It's quite rapid. Do you think, does that worry you in any? I must be exciting in some instances, but also maybe given the nature of the work that you do when it comes to regulation, things like that. That's never as quick as the actual speed of enhancing things. Does that worry you at all? The fact that regulation maybe needs to catch up?
Yeah, I think there are many efforts being made, but yeah, there just has been so much interest in this. And so we have a number of people providing, and yeah, people are doing it in different ways. So I think what we try and do in our business and in our clinical work is just to do it as responsibly as possible. And, I think the majority of people are trying to do that, but it's going to be difficult when there's so much interest. Yeah.
When you say trying to do it as responsibly as possible, is that the things that you discussed, which is, keeping an eye on patients or regular contact, or what, if we were going to go into it, what does that mean?
So what that means is that we consider these agents to be prescription drugs, that we select them appropriately for the right people. So when the right people might need to be prepared before they go onto it. For example, someone may have an undiagnosed eating disorder, and it might be better for them to have that reviewed first. So there is a selection, there's a preparation, there's a counselling that goes with it, and there's a monitoring as well. And it's also being understanding that not everyone's going to respond in the same way. So some people who don't might actually have a decline in their health. So what we don't want is people to just languish on these on treatments, in any treatment, without being reviewed and understanding, do we need to change course? So all of that just needs us to be vigilant and aware that we can't just deliver treatments and then step back, which I think majority of people are not doing.
No, and that makes complete sense, and it's great that there is this focus on that as well. And I think that we're starting to see more of that being highlighted in terms of this is a change in the way you, it's not just a one trick fits all kind of thing. It doesn't just do, it just doesn't have an instant impact. If we think about the deeper patient experience in terms of what the medication, how it impacts them. So we hear a lot of terms like food noise, and that's essentially what it's stopping. How does this actually work?
So these agents work in a number of ways, and I have to say we're generalizing. There's lots of things coming online and new research happening all the time. But broadly speaking, we're talking about the understanding that we now have about the regulation of appetite and the role the gut and the brain plays in this. So we have an appetite regulation center in the brain. So these agents can actually suppress appetite, so make people feel fuller earlier. They can also have an impact on the stomach, slow down the stomach emptying, again giving that same impact of fullness. So yes, the net result of that is people may take in fewer calories. How that feels now, the terms, as you say, food noise, quite commonly used now. Some food, we don't want to eradicate food noise. We don't want people to start developing a relationship where food is, obviously the enemy. So it's just a case of people might end up having smaller portions, for example. The impact that can have on people. So as I said, everyone responds differently. We'd be in the initial phases as we're titrating up certain agents, be talking about tolerability and side effect monitoring rather than weight loss. And actually we're thinking more around health gain and overall health improvement. So people may experience different things. Obviously our relationship with food goes back from the beginning of our lives. So these changes where you start to feel less hungry or you're not eating as much can have different impacts on people. And this is why selection is important, because if you are using food, for example, to blunt or to dull down the noise of a potential trauma in your past, and then you don't have that so much now, then you can imagine that sometimes those things can resurface. So those are things just to be mindful of. But I think on the whole, we're looking at people maybe eating slightly less, sometimes eating very different types of foods. So we've had lots of reports of people changing the kind of nutrients they go for, fewer cravings, all sorts of things come out. But generally it's about readjusting that relationship. And that kind of shifts a lot of things in people's lives. So it is a big change potentially.
I like that you said it was a health shift rather than a weight loss. I think that's a really good perspective to have on it. Am I right in thinking that some people, it's actually when it comes to obesity, it's genetic? There is something in the genes that impacts, so it's not necessarily their fault or their lifestyle.
Yeah, so genetics plays a big role in weight and actually, as it does in height. There are certain, rarer genetic conditions where people have got a collection of symptoms, and that those kind of conditions, you may have more severe weight gain and other features. But yeah, genetics will affect the majority of people. And in fact, it may affect how some people respond to drugs. There's been some interesting research recently because we still don't quite understand why some people respond so well and some don't at all. So that does play a role. And I think it's a nice and it's a good conversation to have with an individual, that there are so many factors. So we always talk about this biopsychosocial elements of obesity. So we're not just talking about what people put in and out of their mouth, but it's about all the things that surround them and drive their decisions and everything else.
What kind of things would that be?
So for example, if you were living in an environment where you didn't have much green space, or your job was quite sedentary, those things clearly impact us and our health. And many other things, the environment where we buy our food and other people around us who support us, our financial situation. So the list goes on. And many decades ago, there was a really brilliant report commissioned by the UK government, which was called the Foresight Report. And that looked at all the factors that sort of drove and sustained obesity. And there were hundreds of them, basically. So it's a complex disease.
That's really interesting. And I suppose if you really went into research, it would bring up all sorts of things like social inequalities and
absolutely,
areas and things like that.
That's why, and I just wanted to add that's why when we as doctors work in this field, we are just playing a very, very small role in my mind. It is about integrated care and collaboration.
And that integrated care is essential, I suppose, because if you are able to afford not just the medication, but like a dietitian or a personal trainer and all those kind of added benefits, then it's going to make a massive difference to your recovery.
Yeah, I would say so.
There's been increasing discussion around the nutritional deficiencies from taking some of these weight loss medications and even muscle loss, how significant is that risk?
Yeah, so I think, again, sometimes when people are living with obesity, actually, it's not always easy to understand, but they are sometimes deplete, and actually quite frequently deplete in nutrients. And the things we come across are vitamin D, folate, for example. So one of those things, it's quite good to consider a person's broad diet, and, a healthy, balanced diet, obviously. When we talked about the calories reducing and the food intake reducing, we would also want to be clear that they're not just reducing the intake of sort of, ultra processed foods, because that would be the kind of thing that would precipitate or aggravate deficiencies. So I think, again, it's about good screening at the beginning, an understanding of a person's diet. Do they have any specific things they're already displaying or are evident? We would say to a lot of our clients to suggest to take a multivitamin, actually, particularly in certain times of the year. So I think those are things that we are aware of and we are monitoring. With regards lean body mass, I mean, I think this is a big area, and I think what we talk to patients and our clients about is maintaining resistance training, keeping moving, good protein intake. Those are the general concepts, but there's obviously a lot more detail to that.
We've talked about a few of the risks throughout this conversation. Is there a risk that patients become overly reliant on the medication without thinking about the underlying behaviours that could be causing obesity?
There is a risk, and again, I think it just comes down to that responsible clinical work, and the decisions that we have, the realistic counselling and discussions we have to have with people, and place these as prescription drugs. So I think all of that would be important.
For patients that are using these medications and perhaps haven't gone somewhere where there is that wraparound care, what are the key things that they should be asking their clinicians about, or going to speak to their doctor about?
Yeah, so really people should be properly assessed at the beginning, obviously based on the provider. People may do that in slightly different ways, but you'd be looking for a really comprehensive assessment at the beginning, understanding the risks and that person's medical history, the other drugs that they're taking, for example, that might have an impact on these newer drugs, and really just to make sure that they're under a regulated healthcare professional who is going to offer them monitoring.
One of the common side effects which people do mention is that kind of change of appearance in their face. Why does that happen?
So various reasons. I think when we have weight loss that is measured and monitored, we don't see that so often, actually. So so what we don't want are people losing weight very quickly, and becoming nutritionally deplete, or not having a broad diet, maybe not having protein, for example. But these things can, there's so many factors involved. So as we age, the elasticity of our skin changes. And we do, one of the things we do talk to our clients and patients about is loose skin, because now we used to talk to people about that when they would go and have weight loss surgery because of the degree of weight loss. But now we're having those conversations for weight loss medicines as well. And we have to roughly say the same thing, just warn people, because it could be a risk if you have quite significant weight loss, and there can be psychological impact. So if people are prepared, that is helpful. But I think it's very difficult to predict. I would say we just aim for balanced diets, and measured weight loss usually is the best way to go.
I want to come back to something that you said earlier on, which is that you've got experience of people who come on for short term, and then maybe some that are on for a longer period. I remember listening to an interview with someone from the British Medical Journal, and he kind of outlined that once you're on these kind of medications, essentially you are on them for life. But there are different instances from what you've said, I take it. So how do people shift to living life without it?
Yeah, that's a really interesting question. So there's one school of thought which I subscribe to is that this is a chronic disease, and as with any other chronic disease, maybe you do need treatment. And it's not for everybody, and it's not appropriate for everybody. There are some people who just need to get from A to B for a certain specific thing. For example, they may have kidney failure and they need to get onto a transplant list. Now, there may be many barriers to them achieving the health that they need to get optimized for that transplant. And that could be because they're on dialysis, it makes them very tired, or they're losing their muscles. So various barriers. So people like that then would potentially really benefit, sometimes do, and again, I would stress that this is under very close and specialized supervision, to have a period of time where we have a clear goal with them. And this kind of support would not just be medicine, it would involve psychology, dietitian, and specialist dietitians actually for that group of patients, to say, okay, what is your goal? And someone may have advised them, we need to get ideally down to the X. Then we look at them to see, is that goal realistic with this particular option? Sometimes it may not be, and we may need to talk to them about other options such as weight loss surgery. So really, again, a personalised approach. And if they manage to achieve what they need to achieve, they most likely will not continue on those drugs afterwards. So that is a group of patients that we do use this in specialist centres.
You know what's really interesting for me from our conversation is you've really hammered home the point that this is a prescription drug. Mm-hmm. So I'm reframing it in my mind because I don't think that fully settled in with me, mm-hmm. because I'm not a clinician. I don't see it that way given the exposure that I've had to it, mm-hmm. and the way people talk about it.
Yeah.
But as soon as you keep saying prescription drug, it's, kind of now I'm associating it with things like statin or insulin,
mm-hmm.
and that then everything makes sense from that.
Mm-hmm.
Do you think that that's part of the problem sometimes with, or maybe not part of the problem with other drugs, but with this one specifically, because there is misinformation online, there is a lot of chat about it. Do you think that is quite harmful?
It potentially doesn't help, and I think there's a lot of stuff out there, and people obviously are influenced by different sources. So I think from our point of view, we just, that's how we like to place it. And it just, as you say, it shifts the conversation a little bit more towards, let's take this seriously, actually. This is something we have to both consider very carefully. I take responsibility for this whenever I prescribe a drug, and you have got to consider risks and benefits. However, that being said, we don't want to put enormous barriers in front of this. That's not what we're trying to achieve. We want these effective treatments for weight management and health to be accessible, but just done in the right way.
Is there anything that you've seen which is potentially you think is quite dangerous, in terms of what people are talking about?
Yes, I mean, there's various things that people are doing because of things are sometimes driven by the cost of what they're paying, advising each other as to maybe take a little bit of this and that. And so we would obviously not get involved in those conversations. We prescribe to license. And yeah, I think when people are seeing things online of people's lives and bodies and, how these things may positively influence people, which they absolutely can, then it can sometimes make that conversation not quite as take it away from that area where we need to be discussing.
One of the things that and it's something that I've seen online, if I'm being completely honest and transparent here, is that I've noticed that a lot of people that are on weight loss medication have found that it's impacted other areas of their lifestyle. So they may have smoked before and they've found themselves not wanting to smoke or not drinking as much.
Yeah.
Have you noticed that through the patients that you've had?
Yes, absolutely. And so we see all sorts of different stories, and that's one of the great things about this specialty is it's just brilliant insight into people's lives, and when people trust you. But I think we have seen there's lots of reports of cravings changing. Yes, I mean, I think
not just for food.
Yeah, not just for food. And I think part of that can also be a general, there's a ripple effect with these things. So for example, if you start moving more, you'll get endorphins, you suddenly feel a bit more like you're sleeping better, the sleep makes your metabolism better. And so there's always a knock-on effect. So if you're in that culture of change and you start to see benefits, then that's one side. But there's also certainly some real biological, physiological reasons we're understanding more about as well.
Now, I know that you kind of work a lot with stigma as well, in terms of a stigma around obesity.
Yeah.
What do you find is quite common in the way that kind of stigma shows up, not just within public, but also within, clinical environments?
Yeah, that's again a really interesting question because it's under-recognized, I think. Stigma is one of the biggest challenges we face when we're dealing with this condition, this disease, and it is sometimes not confronted, it's not even open out there. So many things now are not acceptable in our societies, but weight stigma remains quite prevalent, and I think it has many impacts, but also how does somebody feel when they go and visit their healthcare professional or provider? Do they really feel that this person is hearing their story and is not blaming them? And sometimes people will internalize that and disengage. So I think it's very important to not be judgmental, speak openly. We use tools such as motivational interviewing. We've got some excellent colleagues who work with us and train us in this, just to have, just get that intrinsic change from people. So I think it's very important to non-judgmental language, non-stigmatizing language. But within the healthcare environment, what we see is it impacts on how obesity is recognized as a disease. It impacts on the resources available to obesity. And we will have conversations with people who would suggest that people have taken a medicine for weight loss and that is an easy way out when these people are living with a chronic disease. So there's a lot of bit to it. And other experts, I am not an expert in this, but there are many great experts working in obesity stigma, and it's a really important area.
Is this something that's being brought up a lot more with? Because it sounds like you've got lots of ways that are about empowering patients to talk to you more about this. And is that being rolled out across, or is that education going fast enough, do you think, given that there is a large number of people in our country who are obese?
Yeah, I think there's a lot of stuff happening. There's a lot of work. We need to consolidate our training across our environments. So that's those pieces of work we're working on with colleagues across Europe, actually. So this will be something that's very important in years to come, because I think it unlocks everything once we start to look at that and really challenge it. And there's sort of language matters is another thing that we use as well. It's just about the way we speak. So we don't say obese person, we would say somebody living with obesity, for example, which is
that's really interesting. Just that shift in because it's a disease, and something that sometimes again gets misconstrued when you think about how it's portrayed. I also feel like there's a lot of stigma around people that take the weight loss injections. Have you noticed that shift in, okay, they might have had misconceptions about people living with obesity, but now people have got a whole new stigma for people taking weight loss injections to help them with this?
Yeah, I think that's right. That is quite prevalent as well. So it's just it's just challenging these things when we come across them, I think.
Now, I believe you're also working on personalised care approaches, so social prescribing, reasonable adjustments within NHS obesity services, which we've kind of touched on a little bit. But can you tell us a little bit more about that?
Yeah, so this is where we come back to this biopsychosocial model of obesity and just how prevalent it is as a disease. So it's impacting the whole of society. Now, everybody is going to need a different approach, as we discussed. Now, it's quite common, for example, if someone has learning disabilities, to be living with obesity as well, for various reasons. So what we started to notice was we weren't necessarily giving these people the best care in our services. They were coming in and sometimes waiting in very busy waiting rooms and finding the whole thing quite challenging. So one of the things I did in a previous service was we started to work with a learning disability specialist nurse who would have her own dedicated list. The first thing about that is, do you want to bring people into, for example, a hospital environment for a very good reason, or can you treat them or support them in the community setting? So that's the first consideration. And then from that, it's about making the resources accessible, the language understandable, so that it resonates with people. And there's various other elements around it, which I won't bore you with, but I think we've worked really hard on that. That's one thing. So it's just understanding that within your population, in a clinic or in any private clinic, you're going to get people coming with all sorts of different conditions. And obviously there are other things to consider with that around consent and etc. With regards the other elements around social prescribing. So again, that's another piece of work we set up when I used to work with colleagues in London. That was already set up for another pathway, and we suggested that this might be really good to be able to access if that was possible. So with that, we started to understand that some people might not be able to make a change in their lifestyle or health because, for example, they needed support to fill in some forms or something to do with welfare, and because this was a big stress and pressure for them. So the social prescribers were excellent because they were so connected with the community, they understood how to help these people. And even though so it's almost like we took a sidestep away from what we traditionally do and did that. And then that really had major benefits for our service. So these are all things that I think innovations that we should be continuing to bring, because there's so much complexity. So we can't treat it with just one thing.
If there are clinics that have got this one-size-fits-all approach, because that's what they've always done, what's a good first step or a good way of trying to break that down and be more inclusive in that way?
Yeah, so I think from our point of view, I mean, we're obviously talking in that situation about very complex, big NHS organisations, which is obviously quite different to the kind of people we might see in a private healthcare setting. But I think from our point of view, we'll come back down to the assessment. What are the complications and conditions this person is living with, which each one of them there'll be slight nuances. And in our business, we're developing those models, and we have developed models as to how the things that we give people and talk to them about resonate with them. And I think a lot of that is around understanding their condition, their barriers, putting them in contact with relevant groups and people who may be having similar experiences.
Some of these models, are they things that you've sort of shared with others, or is this something that you do?
Yeah, I mean, yeah, absolutely. We talk widely, and we're very happy to share, because I think this is an evolving field. We're all learning.
Yeah.
So we're really happy to share.
What about the digital tools that might be available when it comes to things like this? Because some of what you've explained can be quite practical, and it's just working across departments and just having those conversations or that communication tied in. But are there digital tools that you've started to look at which maybe help bridge all of it together?
Yeah, absolutely. So we've worked with digital innovation for a number of years, and it's brilliant. It's a fantastic area, and some of these are now endorsed by or have been evaluated by a NICE. So we, a couple of years ago, got a couple of grants from an organisation to embed digital innovation into our NHS services and work alongside our pathways. One of the learnings from that was it's exciting. People will say they'll take it up. They don't always take it up. Again, a different population perhaps to the ones that we see in the private sector. We made a couple of observations, which was that not for everybody. Obviously, we always worry about people who don't have access or aren't
feeling excluded.
But the majority of people now can access these technologies, and I think the benefits would be that we're used to accessing information easily. So if you can have a care plan that's been designed for you, if you can have culturally relevant recipes, for example. So there's some really sophisticated tools in the market, and we're actually part of a collaborative, a UK-wide research study looking at how to evaluate the impact of one of these digital tools in healthcare. So I think there's definitely benefits, but my personal feeling is that given this is a complex disease, a lot of this is about the relationships we form and the continuity of care. Some people really benefit from human contact. I think most of us do.
Yeah.
So it's just how do we weave that together?
When I think, because I didn't appreciate how impactful digital tools were until my father, who has diabetes, got one of the readers that goes into his arm, and the impact that had in him changing his diet is insane. Because for years we had lectured him and tried to help him and given him advice. His doctors had given him advice. They were literally pulling their hair out. And when he was able to physically see it himself, it drastically changed how he lives his life now.
That's really interesting.
And that's when I kind of understood that actually maybe that doesn't work for everyone, but in this instance it's made such an impact on him. He was able to come off insulin. Like, that's a huge lifestyle change, all because he was able to follow his own journey. Are there things like that which have been able to help patients, or are we not quite there yet?
Yeah, I mean, I think there's plenty of really great things. So one of the examples you've just described is this idea of biofeedback, where what we know now is there's lots of information. We know roughly what we should be doing, most of us. Just imparting the information, keeping on giving people information doesn't result in change. So it's just understanding, like, what are the things that are going to trigger change? Are there barriers, for example, as we talked about, anything we can help with? Or does that person need to have that information available to them? Some people really like data and immediately see that impact of what they're doing on their blood sugar levels it's a really powerful way of seeing, right, now I can make an adjustment, let's see what happens, understanding it themselves. We've seen that as well. It's brilliant.
Looking ahead, given that this is quite a fast-moving time, where do you see obesity management going if we look forward 5-10 years?
So specifically in our country, in the United Kingdom, I can see we've got a shift moving from specialist centres, which will always remain because they offer huge amounts of value and experience, but moving to primary care for community access for some of these in the public sector. In fact, it's happening now. That will obviously be a big shift, and I think that's positive because it will help with access for certain drugs if people are eligible. So we're probably going to need to see a lot more training and consideration for how do we resource obesity as a specialty and a disease, which hasn't really had the attention it should have done. I think we're going to see more and more drugs coming and agents coming online with all sorts of different mechanisms of action over the next few years. And we'll start to maybe get closer to understanding when we have a wider toolkit, if we really understand or phenotype that person in front of us, we might be able to really match those therapies more effectively to the right person. So hopefully we'll move closer towards a personalised care approach for obesity. So many other things are changing around dietary interventions, around how we understand psychology, how we talk about trauma and trauma-informed care. And then let's not forget bariatric surgery, which gets forgotten sometimes with all of this, but remains, the most effective evidence-based treatment for the right people as well. Rapidly evolving again. So many things are happening in this field.
What excites you the most about the future of this space?
I think what excites me most is the fact that we'll start to see more recognition of this as a disease and to have much more mature conversations. To be able to offer people the benefit to their health that can be transformative.
What do you think are the biggest risks if we don't get this right?
So what we're seeing is over 200 conditions associated, complications of obesity from involving every organ system. So the impact of that, for example, would be many more people on dialysis, many more people with fatty or fat infiltration of the liver developing cirrhosis. So we're seeing the end stage of these things, and obesity being a big driver in a lot of these conditions. So if we don't get this right, we're going to be picking up younger and younger people with more and more illness. So hopefully we can reverse this or start to slow this down.
It's a good thing we have people like you out there doing the work that you do. If there's one message you'd want healthcare professionals, providers, policymakers to take away from our conversation today, what would you want that to be?
So I think it would be around, yes, the understanding of obesity as a disease, which really shifts everything if we frame it like that, because then we think more seriously about training, about stigma, about treatment, and really think about, with obesity being an underlying cause and driver for a lot of complications, rather than treating the complications, let's look at the underlying cause, which may well be obesity. So if we can put our attention and resource to this, then I think we'll start to really make progress.
Do you think there needs to be a shift in this kind of proactive prescription and, reactive prescription and moving into, do you think this will help that being a bit more proactive? Yeah. So, as you said, if we're catching obesity disease and we're able to sort of, treat that, it's then going to impact.
Yeah, I think we absolutely, if we talk about prevention and a prevention as a healthcare agenda, this is one of the best ways to prevent disease, because we can prevent diabetes, we can prevent heart disease. There's so many things, and even if someone has established conditions, we can start to help with putting those in a better state. So it's a really important target for us socially and across medicine.
Dr. Anjali, it's been so interesting speaking to you about this topic. Thank you so much for sharing your expertise and your insights with us today.
It's been a pleasure. Thank you.
Thank you for watching. If you enjoyed this episode, don't forget to subscribe. You can also follow us on LinkedIn, Facebook, and Instagram. If you've got any questions, feedback, or want to know more about the work that we do, you'll find our details in the description below. Thank you again for watching or listening. We are Health Compliance. We work with new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts. to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.